talk about primarily is facial bones, and we'll talk about sinuses as well. If we had this at the end of the semester, it'd be, I don't know, like a 20-minute lecture anyway, so it's not really adding a whole lot today since the views are common. So let me back it up, say there are 14 facial bones. There's most of them are paired, so you have 2 nasal bones. And we're going to touch on those today because, I'm not real sure why we have that separated out with mandible. The views that we're going to do for nasal bones is very limited. We're going to do 2 laterals and a waters, which is a new view that we're going to talk about in this section. And in my opinion, it's one of maybe only 3 views that we should be shooting in the skull. So you've got 2 nasal bones, 2 lacrimal bones, 2 maxillary bones, 2 zygomatic bones. That's not to be confused with zygomatic arch. The zygomatic arch is the joining of the zygomatic bone with the zygomatic process of the temporal bone. So that's your cheekbones is what the zygomatic bones are. 2 palpatine bones, or palpatine. Now I'm in Star Wars. Told you I'm going into this cold. Like I say, I've been on the road for 7 days. Palatine bones, not palpatine bones. And then you've got the turbinates, nasal conchi, the vomer and the mandible. So we're not going to talk about the mandible today, and we're not going to, we're going to bump on the nasal bones, but for the most part, we're going to talk about the distills. So this is what it looks like from the front. Of course, you've got the mandible. You've got on the inside, you can see the turbinates. That's your conchi. You've got the 2 here and 2 here. On a skull X-ray, it's those things that kind of look like swirls inside of the nose. So you've got 2 nasal bones that are joined at the middle, and then you've got the ethmoid bone that you can barely see, lacrimal bone here. Now on the test, you're going to have a question that asks you about the thinnest and easiest to fracture of the facial bones. And really it's 2. One is nasal bones, that's most common. Airbag goes off in your face and it breaks your nose a lot. Or if somebody gets a little lippy, and gets hit in the face, the nose is pretty prominent, right? So it gets broken up quite a bit. But really the thinnest bone is the lacrimal bone. Full disclosure, I've never seen one break that I know of. I'm sure it happens, but I've just never actually seen it happen. One of our skull phantoms, I don't remember which one, but you can see the lacrimal bone is so thin that you can almost see through it. It almost appears transparent, so it doesn't even look like a bone. I mean, it's opaque, but you can still see like light through it. Kind of like if you put a flashlight up against your hand, you can see the light. Kind of like that. So they're very, very thin. So when you get to that question, the answer is nasal and lacrimal bones, both. So then you got the vomer, which is continuous with the nasal spine, which again is continuous with ethmoid bone and so on and so forth. We talked about that last time. Maxilla, right up front. Maxilla has the maxillary sinuses, so you've got 1 in each side, and they're going to go by different names. So they're the maxillary sinuses, and they're also referred to as the antra of Highmore. So Highmore. Why? I don't know. Look it up sometime. I've never cared enough to look it up, so I don't know. It is what it is, right? So you have sinuses here. You have frontal sinus, and we took a look at that before. You've got ethmoid sinuses, but those are just individual little bitty air cells, and they're difficult to differentiate from each other, from other structures inside of the skull. And then you've got the sphenoid sinus, which is right up under the celluloscope, pretty much in the middle of the skull. Okay, so those are your 4 sinuses that we're going to talk about. We're going to have different views for each one. So frontal sinus, maxillary sinus, ethmoid sinuses, sometimes referred to as a labyrinth, and then we've got the sphenoid sinus, which is just under the celluloscope. There's also a question in there that says all of your sinuses are paired with a possible exception of, and that would be the sphenoid sinus. Meaning there's 2, or at least 2. Okay, so you may look at the ethmoid and say, well, it's not really paired because there's like anywhere from 6 to 20 or something like that. There's a lot of them, little bitty individual air cells. It's kind of like mastoid processes, mastoid air cells. So there's a lot of them. Well, okay, splitting hairs here, yeah, they're not paired, but there's like 20 of them, right? So there's 10 pair. Okay, so the only one that might be a standalone would be that sphenoid sinus. Okay, sometimes it has a septum, so it has two. Sometimes it does not, so it only has one. So that's anatomy of both of those. So nasal bones, again, we're going to talk about that later on, but imaging anyway, but it forms a bridge in the nose, and it also forms a portion of the nasal cavity. So it articulates with each other at midline, so they're fused together, and they're also fused to the frontal bone superiorly, also to the ethmoid bone and the maxilla as well. Lacrimal bones have articulations of the frontal bone, ethmoid bone, the maxilla, and also the turbinates as well, the inferior turbinates. So the smallest bones of the skull located right there at your tear ducts on the inside of the orbit. Maxillary bones is the largest immovable bone of the face. The mandible is the largest bone, but the maxillary is the largest immovable bone of the face. So when you get to this test and it starts asking for alveolar processes, you know, which facial bone has alveolar processes? Teeth, right? That would be your maxillary bone. Nothing else on this test is going to happen. It also forms a portion of the floor of the orbit. And the importance of this is in some of our fractures, if you see, you know, you're looking at this skull model here, floor of the orbit is right here. So what we're going to look at is ways to image possible fractures of the floor of the orbit. So if you've you know, watched any kind of combat sports or anything like that, and they say that somebody got an orbital fracture, there's no such thing as an orbital fracture. There's no such thing. Well, there is such thing as an orbital fracture, but or they may say fracture of the orbital bone. There's no such thing as an orbital bone. What they're talking about are fractures or disarticulations of some of the bones that create the orbit. Okay, so one of those may be the floor of the orbit. So you get hit in the eye with a baseball or a tennis ball or a fist, and what happens is the eye is full of goo, right? So it's kind of semi-liquid, and liquid does not compress. It's the basis for hydraulics. So you try to compress liquid, and what you get then is displacement of liquid, right? So hydraulic jack, the way it works is you move the handle, and it's got a little bitty hole, and it squirts a little bit of fluid into the jack, and it raises the jack. Very, very powerful is hydraulic pressure. So if you mash the eyeball, you get hydraulic pressure. And what happens is that in a lot of cases, you'll have a floor of the orbit blowout. So essentially what you've got is the top of the maxillary bone blows out, and what's directly underneath that is the maxillary sinus. Exactly. So we're going to talk about those type of fractures, and it's what we refer to as a blowout fracture. We're going to talk about those particular fractures in two contexts. One is one view that might show us the fracture itself, and one view that will show us evidence of the fracture. You remember when we were talking about upper and lower extremity, we talked about fat pads in the elbow and the wrist and the ankle and all that. It's kind of like that, only not exactly the same. We can see evidence of a fracture even if we can't see a fracture. Okay, so that's blowout fracture. We'll again talk about that in a bit. So it articulates with all the other facial bones except for the mandible. So everything that we're talking about today, we're going to have articulation with the maxilla. All right. So it forms 3/4 of the roof of the mouth. The posterior portion are the palatine bones. And then you've got the zygomatic process that articulates with the zygoma from part of the cheek. Canthion, we know about the canthion in the anterior nasal spine. Zygomatic bones form the cheek, we already talked about that. The zygomatic arch is formed by the articulation between the zygomatic bones and the zygomatic process of the temporal bone. So articulations would be the frontal bone, zygomatic process of the temporal bone, the maxilla, and the sphenoid. So from a lateral view, it looks like that. So again, we've got the zygoma, we've got the maxilla. Maxilla looks like in this two-dimensional representation that we've got articulation with the mandible. We do not. The mandible articulates with the teeth at the teeth, and then at the temporal bone at the mandibular fossa. So we've got the lacrimal bone here, we've got the ethmoid bone here, we've got the nasal bones here, and we've got the frontal nasal suture, and then articulation all the way around. All right, so the palatine bones, they form the posterior portion of the hard palate. So the hard palate is formed by two things, one being the maxilla, but the other being those palatine bones. So if I were to take this guy's mandible off, we should be able to see that a little bit better. And they really should have made this a different color, but can you see the difference in yellows? So we've got kind of a darker, duller appearing yellow, and then kind of a bright yellow there. Okay, can you kind of see that? All right, so that's the difference between the maxilla, the horizontal portion of the maxilla, and then you've got the palatine bones here. So whenever the bones of, let's say, the upper portion of the mouth don't fuse together, we have a condition known as cleft palate. Right, cleft palate. So in a lot of cases, what we'll have in the defining characteristic of the cleft palate, you're going to have a tendency to think is non-fusion of the palatine bones. It's logical, right? But would you see non-union of the palatine bones? The answer is no. Can you usually see cleft palate? They have commercials on TV for kids in third world countries who can't get that fixed, right? If it was just the palatine bones, that wouldn't be an issue. But cleft palate typically is non-union of not the palatine bones, but the maxillary bones don't come together, and that's where you get what is referred to as hair lip. I know it seems kind of weird. Maybe not a good PC word, but if you think about it, how that came about is that in a lot of cases, in mild cases, it looks like something is holding just a small portion of the lip up, and it can be very severe. And please understand, I'm not comparing them to dogs, right? Kids with cleft palate to dogs, but my mom and dad bred bulldogs, English bulldogs, one time. They had 4 puppies, all 4 of them died. And part of it was because, bulldogs are a mess. They've been bred to look a certain way, and they're great dogs. I love them to death. They have a personality like no other. But because of all that breeding, they have issues. And the reason they cost $2,000 or $3,000 is because they're hard to breed. And some of them had cleft palate. And without that fused hard palate, then they can't get enough traction whenever they try to nurse, and it's fatal, right? So I say all that to say that kids born with cleft palate, severe cleft palate, have a hard life ahead of them. If they can make it through infancy, then they're still going to have a problem swallowing, because you mash your tongue into your palate every time you swallow, right? All right, so the turbinates, I call them turbinates just because that rolls off the tongue better than conche, or conch, any representation of all that. So plural of the conch shell, if you have 2 conch shell, then you refer to that as conch. And I just don't like it. So I say turbinates. So what those do for us is it increases the surface area so that whenever you breathe, you've got more tissue to warm the air before it gets down into the lungs. And the importance of that is that whenever it's cold, you want that air to be warm before it gets into the lungs. Anybody ever stepped into a trauma room in the OR? How's it feel in there?
Ice cube.
What's that?
An ice cube.
The trauma room in
hot.
OR. Yeah, it's hot. They keep it 80, 90 degrees in there. And the reason for that is because, somebody comes in and they have really been in a trauma and they might be going into shock, then their body temperature naturally lowers. So if you have them in a cold, and normally, all of your other OR rooms are freezing cold, but the trauma room, they keep it hot so that the body doesn't have to work to try to heat up the air that they breathe. It's miserable for everybody else, but it results in better outcome for the patient. The trauma room and the ER may be the same way in a lot of cases. They keep it hot just to have the patient breathe warm air, and it helps to keep them warm so that they don't go into quite as much shock. But that's what the turbinates are for. And you've got two upper and two lower. And that's what a conch shell is. So the vomer is at midline, and it is again continuous with the perpendicular plate of the ethmoid bone. You have no articulation on the back side. And then the orbits we're going to talk about in a different portion. So let me come out of that. No, we're going to stay in that. No, we're not. We're going to go down so you can see the sinuses. So sinuses, the purpose for the sinuses is to do the same thing, to warm the air before it gets down into the lungs, and to also act as a resonation chamber. So you notice whenever you have a sinus infection or a clogged nose or something like that, your voice sounds different, right? Okay, so it plays a part in what your voice actually sounds like. But the main functions are to lighten the bone. Anytime you have a hollow place in a bone, is to lighten the bone, provided it's not pathological, but to do that, but also to warm the air before it gets down into the lungs. All right, so development starts in fetal life, but the ethmoids don't fully develop until the patient's 17 to 18 years old. So at 6 to 7, you'll have frontal, sphenoid, and some ethmoids, but all of the ethmoids don't show up until 17 or 18, as well as maxillary sinuses don't necessarily show up until a little bit later in life. Again, referred to as the antra of Highmore. They're kind of pyramidical in shape, with the point being at the bottom and the base being at the top. So, and they are the largest, frontal sinus being the second largest, and it looks kind of like a head of cauliflower, really. And they do vary greatly in size. So this is what we're looking at. So we have frontal sinuses here with the septum right around midline. You got sphenoid sinuses, you can't really see that here, but it's right dead square in the middle. You got the ethmoid sinuses on either side, and then you've got the maxillary sinuses. So you can kind of, if this time of the year, in East Texas, you got all that green stuff blowing around from the pine trees, and you're going to see a lot of people with sinus infections. They've probably seen the CT more than what you're going to see. But you can kind of diagnose where the sinus infection likely is based on where the patient's pain is. If you got a clogged nose and you got a headache suddenly right behind an eye, what do you suppose those are? Or what do you suppose is affected? Probably ethmoid, yeah. If your pain is right in the front, of your cheeks, then that's probably going to be your maxillary sinus, frontal sinuses. You got the frontal headache. So again, we'll take a look at imaging on each one of those. Sphenoid sinuses, I can't really tell you where that pain's going to show up. But in my experience, most common sinus infections are going to be in the maxillary sinuses. All right, so sphenoid sinus, again, normally paired, but sometimes maybe a single sinus. It's going to vary in shape. Usually the two sinuses are asymmetric, right below the soloterska. And that's going to be right dead square in the middle of the skull. Pretty close to it anyway. And so we talked about that. This is labyrinths, ethmoid air cells. Got a lot of them potentially. And that's what all these little, vacancies here look like. So you got them all back through here. And that's a tall, skinny skull. All right. So now let's go back up to facial bones. I should have taken note of where we were.
I think we were like 140.
140. There we go. I don't lose that. Yeah, thanks, sir. All right, so what we're going to do for facial bones are a lateral, a Waters method, which is a parietal and we're going to talk about two different Waterses, and then we're going to talk about a reverse Waters and also a PA axial Caldwell. So the only thing that we're adding new in this case is going to be the Waters. So everything else is the same. With the sinuses, what we're going to add is a SMV. We're also going to do a SMV for facial bones as well. So you can add that on as well. So for lateral, we can do upright or with patient laying down. Doesn't really matter. And it's going to be the same lateral that we saw before. So what were our steps in positioning patient for lateral? Extend the chin until the IOML is parallel or parallel with the long axis of your collimated field, perpendicular to the front of the image receptor, right? That's just for uniformity. And then we're going to put our interpupillary line perpendicular, right? So those were the main two things. And what we were going to look for then were the orbital roofs being superimposed. We're going to look at the mandibular condyles being superimposed for tilt of the head, right? So if we had tilt of the head, then essentially what we had was mid-sagittal plane is tilted towards or away from the image receptor. If the patient was asthenic, if you remember, and you had them laying down, they were going to have a tendency to tilt out that way. If they were hypersthenic, they were going to tilt in that direction. So again, all the steps that we looked at for lateral skull apply here. May have to build up the patient's chest, may have to build up the patient's head, may have to shoot cross table. If the patient's upright, it alleviates some of that. So, use your discretion. Again, if the patient took a pretty good lick to the face, they may be a little punchy. It might not be a good idea to stand them up. So use some discretion. And the only difference then for a lateral for the facial bones and lateral skull is you don't need to include the entire skull. We talked about that when we went through skull. So all we need to see essentially is the facial bones, which starts right about there, right? Because this technically is a skull bone, but all your positioning is going to have you include all of the zygomatic arch as well. So then your central ray location is going to be between the outer canthus and the EAM, about halfway between the outer canthus and the EAM. Okay? So you don't have to include the entire skull. see is the superimposed mandibular rami, superimposed orbital roofs, tersica in profile without any kind of rotation. It should look like that. So what you're going to see in your lateral facial bones, lateral sinuses, lateral facial bones, pretty obvious, everything's going to be superimposed. But a recurring thing that we're going to see in our lateral sinuses is that the sphenoid sinus is going to be the sinus, in our evaluation criteria, the sinus of interest. Okay, so why are we beating on the sphenoid sinus if you can't really identify where the symptoms of a sphenoid sinus infection? Well, it's not that we're only interested in seeing that. It's that what we've got in a lateral is superimposition of everything. So in a lateral of our sinuses, our lateral sinus is going to show us our frontal sinus is superimposed, our sphenoid sinus is superimposed, our ethmoid sinuses are just a mess, and they're superimposed, right? So the only one that you see clearly would be the sphenoid sinus. So it's not that that's really the only one that you want to see, but it is the only one that you see completely clearly. Does that kind of make sense? All right, so waters. Waters is going to confuse you a little bit because our point of reference is going to change. All right, let me get to a good waters. All right, so let's do this actually to make the point. Let's flip all the way back to AP Caldwell. We are looking at page, let's go with PA Caldwell. Okay, so we're looking at page 39. So adjustment of the part. Adjust the flexion of the patient's neck so that the OML is perpendicular to the plane of the image receptor. Okay? You good so far? You flip over to AP Caldwell, it's the same thing. You flip over to towns. So what are you lining up for the towns? What are your 2 points of reference for position? OML or the IOML and the image receptor, right? Now if you flip over to page 65 and you take a look, what are your points of reference here? It says, rest the patient's head on the tip of the extended chin, hyperextend the neck so that the OML forms a 37-degree angle with the plane of the image receptor. All right, so what we've done then is we've taken our skull cap and we've dropped it on the podium. Let's go ahead and drop it on the floor. I've done that with a lot of them. Anyone that you see without a skull cap? I did that. All right, so what we're going to do then is we're going to extend the patient's chin until we've got the basically the mentomeatal line perpendicular to the image receptor. So mentomeatal line from the point of the chin out to the EAM is going to be perpendicular to the image receptor. The orbitomeatal line is going to form a 37-degree angle with the chin fully extended, okay, until the mentomeatal line is perpendicular. So you're going to have two waters. You've got an original waters, which puts the mentomeatal line perpendicular to the image receptor. Now, what we're trying to accomplish here, now that I got his skull cap on, I'm going to take it back off. If I were to shoot just straight PA, then our petrous ridges, which are right here, are going to be projected into the orbits, right? If I pull my chin back a little bit, where are they going to be now?
Below the orbit.
Below the orbits, and what's right below the orbit?
Maxillary sinus.
maxillary sinus, right? So is that going to be good for us?
No.
The answer is no. With it down like this, we might have some C-spine in the maxillary sinuses. So if we pull back far enough, I can drop my petrous ridges below the bottom or the floor of the maxillary sinuses. Okay? So pull my chin back far enough so that the mentomeatal line is perpendicular to the image receptor. And what I do is I place that places the petrous ridges below the maxillary sinuses so that the maxillary sinuses are the sinuses of interest. Okay, that's for sinuses. Now, what do I see in facial bones with the waters? And that would be this. So 37 waters shows us almost everything that you would want to see in a skull, or in skull, facial bones, sinuses, whatever. It might not show everything ideally, but it's going to show you everything. All right, so 37-degree waters, we tilt the chin back far enough to put the petrous ridges below the bottom of the maxillary sinuses. Okay, so can we see the maxillary sinuses now?
Mm-hmm.
The answer is yes. Can we see frontal sinuses?
Mm-hmm.
Yeah, we can. Can we see the ethmoid sinuses? No, but you can't really see them anyway. They're going to CT. All right, so what is this? It's a odontoid process, right? So if you were to come directly up from this, well, you got the mandible coming across here. But if we were to take that patient in the 37 waters, our maxillary sinuses, or our ethmoid sinuses right there, if I were to open the patient's mouth, where would that sinus be projected?
Right in the middle.
Right in the middle of the open mouth. Right. So we can see all four sinuses with just this one positioning, right? There is a 37 waters in sinuses, and there's also a 37 waters with the open mouth. That's open mouth waters. It used to be referred to as a PIRI method, P-I-R-I-E. And it incorporated an angulation. We'll talk about that here in a minute. But in this one set of positions, we can see all four sinuses, and we can see the most commonly broken bones in the facial bones. So this is going to be a projection for the facial bones. What we can see then is the nasal septum. So if a patient has broken nasal septum or deviated nasal septum, we can see that. Okay. It also puts the floor of the orbit pretty much perpendicular to the image receptor. So if it's possible to see that blowout fracture, we might see it here. You're probably not going to see it, but what's right below the floor of the orbit? Maxillary sinuses. So if you blow that out, then it's probably going to come with some tissue damage as well, some soft tissue damage. What do you suppose is going to happen here?
They're going to fill.
Whichever one gets hit, it's probably going to fill up. So even if you can't see the fracture, you can see evidence of fracture because the patient's going to have what appears to be a sinus infection. Now, might a person who has a sinus infection also get hit in the eye and have a blowout fracture? Yeah, it could happen in rare circumstances, right? But most of the time, if somebody has a blowout fracture and they have a occluded singular sinus, then that indicates the patient has a blowout fracture, right? So it might not show the fracture. It's the best view to show the fracture, but it might not show it, but it'll show evidence of the fracture, and that being fluid in the sphenoid sinus. So what else? What other fractures? Could you potentially see a fracture of the skull?
Depends on what it is.
Depends on where it is, but yeah. If it's a basilar skull fracture, could you see that? No, you couldn't. So that's one of the other views I say is important view of the skull would be a Townes. A Townes shows you your, basilar skull fracture. Okay, so Townes, Waters, and lateral, in my opinion, are really the only three views of the skull we ought to be shooting. That's just my opinion. Because you can see all sinuses, you can see skull fractures, you can see some of your facial fractures. Like, okay, you lay on your back and you look up at the clouds and you see stuff, right? We walk through that when we're talking about the Scotty dog and L spine, right? Scotty dog, you kind of got to use a little imagination. Well, we got something here too that we can look at to determine whether or not we've got a good Waters. And that is, we've got this great big flappy looking thing, right? And then we've got, and this is kind of hard to see on this, it will probably show up better, in the PowerPoints or if you're looking at the Waters in your book, but you've got this thing that kind of comes down and flattens out right here. So it's kind of tubular looking thing. You got this kind of a bump right here, big flappy thing, little tubular thing, kind of looks like an elephant. Can you kind of see that? Ear of the elephant, forehead, and that would be the trunk. And obviously what forms the ear would be the orbit. What forms the trunk would then be the zygomatic arch. All right, so that is, your behind, let's say, nasal bones, mandible, that would probably be your third most common fracture of facial bones. Another fracture of facial bones that will be referred to as an orbital bone fracture is what we refer to as a tripod fracture. What a tripod fracture is a total disarticulation of the zygoma. So you got the zygoma, you get disarticulation at the zygomatic arch, or zygomatic process of the temporal bone. You get disassociation at the upper end, that would be from the sphenoid and the frontal bone, and then you get disarticulation at the maxilla. So essentially your zygomatic bone is just kind of free floating. Okay, so again, zygomatic bone fracture could be referring to that. Or not a zygomatic bone fracture, but orbital bone fracture could be referring to a tripod fracture. Tripod fracture, you've got connection here, here, and here. All 3 points of articulation are gone. It's broken. Okay, so you can see everything. You can see the entire skull with the exception of possibly your basilar skull fracture. You can see it on the Waters. All right, so remembering that anything that you do PA, you can do AP. All right, so in this case, though, what we're going to do is we're going to shoot AP, and it's going to be a acanthoparietal projection. So this is parieto-acanthial, acanthoparietal. So what you're going to do is if the patient's in a collar, you're hoping that their chin is extended enough that you can just, shoot it kind of like what you would a DENS with perpendicular central ray. If it's not, then what you're going to do is you're going to angle your central ray until it is parallel with the acanthomeatal line. Okay? So, AP Waters, really the only difference between the two would be the eye dose and the appearance of the orbits. Again, the appearance of the orbits would be magnified. But you can do AP as well. Acanthomeatal line, mentomeatal line. Angle your central ray parallel to the mentomeatal line. If you can't get the mentomeatal line perpendicular to the image receptor. Reverse Waters. Okay? Modified Waters is going to be positioned with the acanthomeatal line perpendicular. Okay? So instead of having just the chin on the image receptor, what you're going to have is the chin and nose on the image receptor. Okay, you're going to have a tendency to look at your angulation again, and you're going to have a tendency to think that a 55 Waters, bigger number, is going to require more of a flexion of the neck, and it's not. Okay, So what we're gonna do is we're gonna come down to where our orbital meatal line is more perpendicular. Perpendicular, what's your angulation? 90-degree angle, right angle we call that. Or what degrees is that? 90, right. So in this case, we're gonna tuck our chin a little bit, and we're gonna put the nose and the chin on the image receptor, and that's gonna be a 55 waters. Okay? So with a 55 waters, what we get is truly the floor of the orbits are gonna be perpendicular to the image receptor. Okay, where the 37 was close, it was a little bit of an angle, and if you think back to our, our interphalangeal joints, if we have any kind of a bend in our fingers whenever we shoot our hands, what happens to our interphalangeal joints? They close, right. Or if you don't use central 15-degree angulation on your central ray for the toes, what happens to your interphalangeal joints in the feet? They close, right. So if the floor of the orbit is not perpendicular to the image receptor, then we could close that fracture up. All right. So by tucking the chin down just a little bit, the floor of the orbit becomes more perpendicular to the image receptor. And with it more perpendicular to the image receptor, you increase the chances that you're going to see that blowout fracture. Okay. So might you see it? Probably not. Increases your chances of seeing it over the 37 waters. So between the 37 waters showing you the maxillary sinuses and the 55 waters showing you the floor of the orbit, then your chances are increased that you can make a diagnosis of the patient has a blowout fracture. Okay, so acanthomeatal line perpendicular, 55 waters, mentomeatal line, 37 waters. In sinuses, we're going to use the 37 waters. And facial bones, we're going to use both. We're going to use 55 to show us the floor of the orbit, 37 to show us the sinuses, 37 also shows us the zygomatic arches as well, tripod fracture. We can diagnose all those things. Okay? And you can also do that in reverse as well. So it's reverse, and notice the difference between these two. Okay? So what does that sinus look like?
Pyramid.
Full of air, right? What about the other one? Not full of air. So what can we conclude? Well, maybe the patient has a sinus infection, maybe the patient has a blowout fracture. Not any kind of history, we don't really know. Since I don't see any kind of odontoid process here, I gotta assume that this is probably a phantom. You also don't see any frontal sinuses in this guy. So, does he not have any frontal sinuses? Did he have a sinus infection, or just did some of the acrylic leak into the sinus? I don't know. So either this guy had a total decapitation, or this is a phantom. One of the two. I would lean towards a phantom. All right. So Caldwell. Going to be the exact same Caldwell that we looked at before. Remember that the Caldwell only incorporates that 15-degree angulation. Can be done AP or PA. If it's PA, which is preferred because of the idos, then we're going to use a 15-degree caudal angulation. And just like what we talked about in skull work, the more of an angulation that we put on our central ray, the further we're going to push those petrous ridges down. So if we use as much as a 30-degree caudal angulation, some people will still refer to that as a Caldwell, just a 30-degree Caldwell. It's not truly a Caldwell, just 15 degrees is Caldwell. But what we're going to do is we're going to press those petrous ridges all the way down into the top of the maxillary sinuses. So then what we've got is kind of an evaluation criteria that looks an awful lot like a 55 waters. With the 55 waters, what we have are the petrous ridges projected into the maxillary sinuses. With 30-degree Caldwell, we get exactly the same thing. So the evaluation criteria reads an awful lot alike, but the images don't look the same, because with that central ray angulation, the face looks kind of exaggerated and extended, distorted, right? As opposed with the waters is not going to be as distorted. So 15-degree caudal angulation exits at the nasion. You know, if you want to see the inferior orbital rims, then we're going to angle 30 degrees caudal. We're going to look for the same evaluation criteria that we look for in the skull. So 15-degree caudal angulation for Caldwell, again in the lower third of the orbits. So zygomatic arches. Any questions? Anything we've done so far? So the PowerPoints have the zygomatic arches have the zygomatic arches singled out away from the facial bone, but it's going to be part of your facial bone series. So what we get with our zygomatic arches, or how we image our zygomatic arches, they're kind of tough, really. So what we've got is depressed fractures of our arches. So if somebody gets hit in the cheek really hard, then, and this could be caused by anything, and there's somebody who had a depressed fracture of zygomatic arch from a water skiing injury, of all things. Skiing along, wiped out, ski came up, hit her in the cheek, and she had a depressed fracture of the zygomatic arch. So the problem is, all right, so if I position this just without any kind of rotation at all, can you see the zygomatic arches?
Mm-hmm.
No. So if you have then a depressed fracture of one of them, how much more difficult is it going to be to show them? A lot. All right. So the things that we're going to do to try to show that, the SMV, positioning the SMV is going to be just like in the skull. You want the infraorbital meatal line parallel to the image receptor, or at least the central ray perpendicular to the IOML. Okay. But what you can do to kind of project these out and away from the top of the skull is to take advantage of the divergence of the central ray. So does the central ray diverge more at closer SIDs or further? Closer. You have a wider angle, that's shorter SIDs. So if I'm trying to cover a certain area and I'm only using, I'm using this full length here, then the divergence of my central ray is not going to be very great, right? But if I'm only using this much of it, then the divergence is going to be quite a bit more, okay? So the divergence is worse at, or in this case really better, at lower SIDs than what it is at greater SIDs. So what you can do is bring your central ray in. I've got about 15 feet here, but if you were to bring this in, then what we would get is magnification of the zygomatic arches. Remember, anything that's closer to the image receptor is going to show less magnification than anything that's at an elevated distance from the image receptor. So zygomatic arches being further away than the fattest portion of the skull, what we're going to have is more divergence of the central ray. Is going to catch that, and it's going to magnify them out and away from the top of the head. Sometimes you'll see these patients who've got a light bulb head, right? I mean, this portion of their head is a whole lot more broad than their face, right? So you may have to bring your central ray in to, 30 inches or closer even in order to take advantage of that. Sometimes that's not going to work. So what we're going to have to do then is to take the patient and we can tilt them just a little bit. Now watch what happens. As I tilt this patient's mid-sagittal plane, we're going to tilt the mid-sagittal plane towards the side of interest, and now I can see, right? I can see just one of our zygomatic arches. So the one that's going to show is the side that the face is tilted more towards the image receptor. Okay? So if I'm interested in the right, then I'm going to tilt the top of the head to the left. Okay, and I make that distinction because I want you to pay attention to the wording on the tangential, so it's page 77. Tangential is zygomatic arches. So hyperextend patient's neck and rest the vertex, the top, on the image receptor. Adjust the position of the patient's head so the IOML is parallel as possible with the plane of the image receptor, just like every other SMV that we've done. Now it says rotate mid-sagittal plane of the head approximately 15 degrees towards the side being examined, and then it says tilt the top of the head approximately 15 degrees away from the side being examined. Does that sound like a contradiction? It kind of does, but it's not really. So what it's saying is that you rotate towards the side being examined, and then you tilt away from the top of the head, away from the side being examined. So tilting the top of the head away from the side being examined is doing that. So what is rotating of the skull doing? Really not much. You know, and if you forget one of those two things, don't forget the tilt of the head. Okay? But what the book is saying is rotate and then tilt. Okay, so it's not really a contradiction. It's rotate towards the side of interest and then tilt the top of the head away from the side of interest. Okay, you see that? It's okay. Oh, also on zygomatic arches, you don't have to do these in the bucket. What you're looking for is a small bone, you know, a little bitty thin bone through a little bit of soft tissue. You don't have to shoot it in the bucket. So where you have a little bit more positioning latitude with the patient is if you're doing it tabletop, you can take the image receptor out of the table and have the patient hold it above their head, not above their head. They're laying on the table, have them hold it, right, and just extend their chin. You don't have to get the entire skull. All you got to get is zygomatic arches. So you've got a little bit of positioning latitude. You don't have to have the patient, you know, built up on sponges to put the vertex of the skull on the table. Still, if you're doing it upright at a wall bucky, you know, put the patient in a chair that has a backing on it, you know, and have the patient lean back. So a little bit more positioning latitude. Column 8, central ray enters mid-sagittal plane of the throat, about 1 inch posterior to outer canthus. Don't need to get them all. Zygomatic arches, depressed fracture here. Again, you can shoot this tabletop with about a foot technique, hand technique maybe. Doesn't take a whole lot. Tangential should look like that. And again, on your tangential, you're just looking for one, so you can collimate down to almost nothing for your tangential. So what if you do all that and you still can't get it? Well, you can do one other thing, and that would be a Townes. So Townes, the positioning is just like what we talked about before. AP of the Townes with the 30-degree caudal angulation if our orbital meatal line is perpendicular to the image receptor. If you're using the IOML, increase 37. So you're going to need the grid with this one. And our central ray location is going to be just a little bit lower. So approximately 1 inch above the nasion. And that's what we should see. So we don't need, again, the entire skull. We can collimate down to a smaller area than this, but these are the zygomatic arches here. Can be tough to image. know nasal bones are on a, supposedly on a different test. I think there are questions on this test, or a question on this test on nasal bones. So our nasal bone series typically consists of a 37 waters. So I'm just showing you this AP so that you can see what happens whenever we pull the patient's chin back. So the nasal septum becomes more vertical, right? So what we're going to be looking for in nasal bones is deviation in nasal septum on our waters. So we're going to do 37 waters, and then we're going to do both laterals. Now, lateral in this case, positioning-wise, is going to be the same, but our central ray is just going to be to the nasal bone, just about a ½ inch distal to the nasion, and our collimated field is about the size of your thumb. You just don't need a whole lot, okay? So that will be your nasal bone series. It's 37 waters for the nasal septum, both laterals, because your bones, your nasal bones, you've got two of them, and both of them are kind of at a funny angle to the central ray. So you can do both laterals and a 37 waters for nasal bones. All right. So this is what I proposed. It's 9:02, and I got maybe no more than 10 minutes worth of material left. I say we press on and not take a break. Y'all okay with that?
Yeah.
Good? Okay. All right. If you're just about to explode and you need to go to the restroom, go for it. But we're just going to press on. So lateral nasal bones, that's what they look like. So sinuses, we kind of talked about most of this. So we're just going to run through the projections to make sure that we kind of have them separated from facial bones. One thing I want to draw your attention to on the sinuses. All right, I'm going to go through my checklist of, zipper up and all that. I'm giggling over there again.
Is there labeling on this test?
Pardon?
Is there labeling on this test?
Yeah.
Okay.
There'll be labeling on all the tests from this point.
Okay.
So in this, I had an eye on the image I wanted to show you. Okay, so if you have your textbook out, look on page 96. You remember on the, whenever we first started covering chest x-rays, if we wanted to see a pleural effusion, what did we need? Decubitus, right, we needed to see decubitus. And what are the, the steps, what makes a decubitus image? Horizontal central ray, somebody said it. So you got a horizontal central ray, and between the images on page 96 and 97, you see what the horizontal central ray does for you. So if you back it from 97 to 96, so you take it in reverse order, what you're seeing on 97, on page 97, figure 11-168, is a vertical central ray. So they put this coconut, this is a coconut, they put this coconut on the table and they shot a vertical central ray into the coconut so that the fluid always finds its own level. The fluid is completely filling the bottom of the coconut, so you don't see any air fluid level at all, right? You can see that there's something there. You've got the outer cortex of coconut, and there's something on the inside. So with 11-167, though, you start to see some air fluid levels. They're not clear, though, right? So if you look at the bottom, and some of the paint jobs on some of the cars, they kind of fade, right? They go from like black to gray, and it's just kind of incremental. That's kind of what you're seeing there. is it's going from a very light to a very dark, but it's kind of incremental. It's light, and then it's gray, and then it's really dark. All right, so that's what you get with a angulation, but that's a 45-degree angulation. It's pretty significant, right? And then whenever you have a horizontal central ray, though, like in 11.166, what do you see? Clear delineation, right? So you can see air fluid levels and clear delineation. So what we need to see in our sinuses is that. So you're going to have test questions that ask you, what is the orientation of your central ray for sinuses. So a distinguishing characteristic of sinuses versus everything else in the skull is that according to the textbook, you need a horizontal central ray. So one of the views of the sinuses, though, is Caldwell. So what is a Caldwell? What do we do with Caldwell? Angled central ray 15 degrees caudally, right? So what we do is we put the orbital meatal line perpendicular, right? And then we angle our central ray 15 degrees caudate. With the Caldwell for the sinuses, then what we're going to do is we're going to maintain a horizontal central ray, but we're going to tilt the patient's chin back just a little bit, 15 degrees. So the orbital meatal line forms a 15-degree angulation. Okay? So extend the patient's chin a little bit, not as far as for a 55 waters, but it's not going to be perpendicular either. It's going to be 15-degree angulation. Okay? So, now, that's for the test. You got to have a horizontal central ray. Sinuses, horizontal central ray, right? So you can see air fluid levels. I'm going to refer you back to page 96. Can you see air fluid with a 45-degree angulation? You can see where the air is. You can see where the fluid is. Can you see a clear mark? No. But can you see that there's fluid there? Absolutely. Absolutely. That's with a 45-degree angulation. All right? So do you think it's going to be that dramatic with 15 degrees? The answer is no, it's not. So for the test, though, what do you have to have? Horizontal central ray. If you're doing sinuses with somebody and they put a 15-degree caudal angulation on the central ray, is that going to interfere with the diagnosis? Almost certainly not. Okay? So, don't put yourself at odds with the technologist if they put a 15-degree caudal angulation on a Caldwell for sinuses. It's just not going to matter all that much, right? Is it ideal? No. Should you use the head tilt method instead of using angulation of central ray?
Sure.
Absolutely, you should. What if the patient can't bring their neck back? You just don't do a Caldwell? What if they're in a halo? They got a broken neck, right? Can they bring their chin back if they're, got these pins in their head? No. A 15-degree angulation, is it really going to be that vital? It's not ideal, but it's better than nothing, right? So, anyway, for the test, though, what are you going to do? Horizontal central ray. Very good. Very good. All right. So lateral, we're going to do the same lateral as what we did before. It's going to show all 4 sets of sinuses, but which one does it show best? Sphenoid. Right. Right. So lateral, all the same stuff. Our central ray is going to be 1/2 inch to 1 inch posterior to the outer canthus, which is almost at the same place as what we saw for the facial bones, right? That's what we should see. Frontal, maxillary, ethmoids are somewhere in all that mess. Sphenoid sinuses here. I can't say that we don't have some sort of fluid in that. Caldwell sort of. You can angle the grid if you want to. Just a little better consistency, angle the grid 15 degrees. If you happen to be working with a machine kind of like what we have in the lab, you can angle the grid and maintain the horizontal central ray. You can be more precise that way. Alright. Get through all that. And it looks like that. So Caldwell is going to show us our frontal sinuses. Our maxillary is going to be on waters. It shows here. 37-degree waters. We don't have a 55 waters for sinuses. Only 37-degree waters for sinuses, 55 and 37 for facial bones. All right, and then this was actually out of a previous edition of Merrill's, and I think these images were actually from the Peary method. So this is the open mouth waters. And if you remember, I started off this semester telling you that you needed to clean off the image receptor and do it in front of the patient, right? Wipe it down, especially if you're doing sinuses, for this reason. Because what you're going to do is you're going to position just like a waters. So you got your 37-degree waters. Mental meatal line is going to be perpendicular to the image receptor, right? So you got this going on. The thing is, though, if you position and you push the patient's face all the way up against the image receptor, and then you tell them to open their mouth, because it's open mouth waters, right? So if you put their chin all the way up against the image receptor and then tell them to open their mouth, what's going to happen?
Tuck it back.
Exactly. Now am I at a 37 degree?
No.
No. So what you need to do is position, pull the patient's chin back a little bit, and then just tell them drop their chin. You know, be real specific with your wording. You know, if you tell somebody open their mouth as wide as they can, and this applies to open mouth odontoid, this applies to open mouth waters. You tell somebody to open their mouth as wide as they can, what might you get? No. Right? So just, you like sound effects, do you? So instead of doing that, just tell them drop your chin, right? Then you can say, you know, open as wide as you can. And so what you should project then is sphenoid sinus through the open mouth. Okay? And I think, SMB. Also, we do an SMB as well. So in this case, the SMB is going to be positioned just like everything else, every other SMB that we've done, and that is the infraorbital meatal line is going to be parallel to the image receptor. If you can't get that, then your central ray has to be perpendicular to the IOML. Now this is where on the test it's going to be a little bit of a deviation because of hammered horizontal central ray. I think the answer on the test here is going to be central ray perpendicular to the IOML. Okay, so even on sinuses, you're going to try to accomplish, you know, IOML parallel to the image receptor, but if you can't get that, then your central ray still has to be perpendicular to the IOML, even on sinuses. Okay, that's a question on the test. You know, a lot of times people trip over it.
What,
Don't
so
miss
what's
it.
the question? What would it be?
It would be perpendicular to the IOML. So if the patient can't get their IOML parallel to the image receptor, you would angle the central ray perpendicular to the IOML.
Okay.
Yeah. Okay. And that's what it would look like. So we've got the sphenoid sinus here. And so again, we've got the maxillary sinuses are superimposed on themselves. You're seeing a superior to inferior view of the maxillary sinuses. Ethmoids are still a mess. Frontal sinuses you can't see because everything's projected on top of it, including the upper and lower incisors. So really the only thing that you see on this one is the sphenoid sinus. Okay, any questions?